I think it would be helpful perhaps if you could start by saying who you are, so we've got that on the screen. And I don't know if you brought a statement, if you'd like to start with that perhaps, and then take a few questions from us.
Okay, that's fine.
Okay, so if you'd like to start, that would be good.
So my name's Myra Robson. I'm a specialist pelvic health physiotherapist, and I work at Lewisham and Greenwich NHS Trust in South London. I'm also involved in other pelvic health initiatives and created Squeezy app, which is a pelvic floor exercise app, and it is that led me into mesh in the first place when Kath Sansom contacted me about Squeezy and about conservative measures for pelvic floor problems. And as a result of that, I became involved in Kath's work and in the Sling the Mesh group. She invited me to join the group, and over around about the last 2 years I've been involved in the group as the situation has escalated, and my role has been to help with clinical advice and answer questions when they come up, and also to act as a bridge between the mesh injured community and some of the medical professionals, and to try and start the conversations going about the way forward and how we can improve the current situation.
Right, thank you very much. And have you got a statement you want to make?
So really what I was going to say with my statement was that I feel that the role that I've taken is quite an unusual one. I don't think there's many people that have got a foot in each side of the camp. So I think I've got quite a unique viewpoint in understanding how the mesh injured community, particularly women, because it's mostly the gynae mesh that I'm involved with, are feeling, and how they're responding to changes that are happening both in the news, such as the news we've had this week about the devices, and about the progress that gets made with the mesh situation, with the review body and so on. And so I'm really keen to use my position to help support the path going forwards in any way that I can.
Thank you very much indeed. I think last time we spoke, you did actually say that you are supported by various organisations, and I'm not talking about, I'm talking financially. Is that right? Have you got any?
So the only support I have is for a group called Pelvic Raw, which I run with 2 other physiotherapists, which is a social media group for pelvic floor issues, and we have some sponsorship for running our website and for our trademark by Living With, which is the company that makes Squeezy app, and by 2 other product companies.
Right, thank you very much indeed. Can I ask you, from the point of view of, I mean, you've declared your interest, which is great, but do you find that there are other conflicts of interest within the whole of this area, perhaps conflicts of interest from the pharmaceutical industry, or surgeons being influenced, or the MHRA, or are there any issues there that you think we should explore?
Not that I have seen. In the hospital I work in, I worked with a consultant for a while. This was when it was at its height, probably about 8 to 10 years ago. I'm not aware of any of conflict of interest, but being a relatively small hospital, we don't see as many of the reps or receive as much of the financial support as some of the bigger hospitals. So for the work that I've been involved in, I haven't seen that.
All right, thank you very much. And can I ask you, you talked about 2 camps, and if you'd like to say a little more about the camps, and whether you feel there is some consensus, albeit that you've described 2 camps.
I think gradually over time that the majority of the mesh injury community and healthcare professionals are starting to see that actually there are more problems with mesh than we had first realised. A lot of the mesh injury community have huge amounts of anger and also anxiety and fear, and I can understand that position, because they feel that they have had a treatment that was perhaps unnecessary, perhaps not consented for, or not consented for fully, was offered when they could have had an alternative such as physiotherapy or pessaries, and these were either not offered or not explored fully enough. And some of them have expressed feelings that they've been operated on for reasons that were just incorrect. So perhaps financial incentives, or the surgeons were just in a position of power and using that in a way that was inappropriate. I think over time that the work the review body has done, which has been extremely positively received by the mesh community, and the latest research on mesh and on medical device in general, is helping them to see that actually, although there is a problem, it wasn't necessarily coming from the wrong reasons, that there have been some genuine mistakes that have been made. From the terms of the healthcare professionals, I think the same thing is happening. When it all started, I think a lot of the mesh injury community were viewed as being perhaps hysterical, creating a buzz on social media that was unhelpful, and perhaps some of the symptoms, because the reported symptoms can be quite unusual and difficult to objectify, that perhaps that they were exaggerating or making these symptoms up. I think as time has gone on, the volume of women, the volume of symptoms that are being expressed, and the evidence that's coming forward is helping the healthcare professionals to see that there is more solid evidence for what's being reported. So I can see that there are moves being made to bring the two sides together and to get a little bit more mutual understanding.
So is there a greater warmth now towards physiotherapy?
I think it's getting there, yes. I think more of the pelvic health physiotherapists in the UK are gaining an understanding of mesh, and I'm trying to make sure that the message is spread wherever possible. We still have a big challenge in educating the musculoskeletal physiotherapists, which make up a much larger body of the profession. And one of the problems is that women with mesh complications may go to their GP as a first point of contact. They often will present with symptoms such as groin pain or back pain, and then are being referred to a physiotherapist. Not necessarily inappropriately, it's a good place to send someone with back pain, but those physios may not be fully understanding of mesh, and again, that's not unreasonable. And then these patients are perhaps being treated in a way that, although it would be completely appropriate for an average back pain patient, is flaring up a mesh-injured woman quite considerably. That is still causing some concern, but I've worked with the group, particularly the Sling the Mesh group, to help them to see that actually it's a specialist pelvic physio that they would want to see, and to be open and discuss their mesh problems with anybody else, with the idea that if a physio is not familiar with the topic, that they can then come and speak to me, look it up, become familiar with it. So I think we're starting to avoid some of the flare-ups that were happening, and I think that situation is improving, but I'm working with my professional body to try and find ways of spreading the word further and educating everybody.
Well, that's very encouraging. Thank you. So,
how many schools of physiotherapy are there in England now?
Oh, that's a question. I really don't know. But pelvic health physiotherapy is not taught as an undergraduate subject for the majority of schools. It's a postgraduate training, and that's partly why there are far fewer of us than there are of generalised physiotherapists.
Is there still one at King's?
There's a school of physiotherapy at King's, yes.
Yes. And what connection would you have with that? Because that will be your local one, so to speak.
Yes. At the moment, I haven't made any connections with any of the schools of physiotherapy. I've been working with the professional body to try and get information out more centrally.
But how will the training take place then? Will the professional body do it, or will they do it through the schools?
Well, in terms of mesh, what we think at the moment is that it doesn't actually alter any of our assessment or treatment options. We work on treating the individual, and that's exactly the same position no matter what the complication is with mesh, or whether they're removal, post-removal, etc. So it's about understanding what mesh can do to the body, what presenting symptoms may be, how irritable the condition is, and how easily flared up symptoms can be, and then working around that rather than specific techniques. So it's much more of a theoretical training that's needed, which is why I'm keen to use websites, journals and so on.
There will be clinical interventions to be researched and outcomes to be measured. And the usual way of doing that is through some sort of academic base. Correct?
Yeah, that's a very good point. At the moment, one of the problems I've got is that all of this is done in my spare time rather than part of my job. So yes, the list of things to try gets longer.
But your professional association is the What is it?
Pelvic obstetric and gynecological physiotherapist.
And what connection do they have to the big professional body?
So it's a subsidiary of the Chartered Society of Physiotherapy. Yeah.
Right. So do you have any connections to the Chartered Society?
Yes, and I am in discussion with the head of the POGP, and also she's in discussion with the CSP, and I've made links with another training person.
Do we need
CSP.
a national strategy?
I believe we do, yes.
So how can we help, as a review, develop that? Should we meet the Chartered Society? If so, who do we meet? How
yes,
do we do
I think
it?
that would be really positive, and also involving the POGP in discussions would be a very positive move too, and supporting some time to allow sort of some of the specialist physios to spend some time
Well,
planning
we
this
only
out.
make
Would be good.
recommendations, but we have to make practical recommendations.
Yeah, I think some time is important. So there are several of us who are interested in the mesh complications and have some experience of it, and having any support with that to put guidelines together, I think would be very positive.
Thank you.
Can I just ask about the relationship with surgeons, consultants? So if we take a situation where a woman doesn't have a physiotherapy intervention, but ends up in front of a surgeon discussing surgical options for SUI or prolapse and measures of consideration in that context, how likely, in your experience, is it that a surgeon would say, actually, you ought to try physio first before I go anywhere near you?
My experience is very individual. I think we're getting more towards referring to physiotherapy as a first line, but there are some surgeons who even now still don't really believe that physiotherapy is a good option, partly because of the adherence to it. So we know that for SUI, for example, that the evidence suggests you need a 3-month program of exercises, and you need to be exercising up to 6 times a day. And so understandably, the adherence tends to be quite low. But we know that it works. We also know that waiting lists can be long, and not all hospitals will have specialist pelvic physiotherapy access. So that does make it more difficult for some of the surgeons to choose it as an option. But I think with all of the mesh issues we've had, and obviously it's the first line in the NICE guidelines for SUI, I think we're getting more interest in it, and more women are being educated as well and asking for physiotherapy as a first line treatment.
So you don't see a sort of, as it were, a cultural problem amongst surgeons? Or
I think there's an element of it still. I've certainly worked with consultants who are not particularly interested in physiotherapy, and even in my own hospital, some surgeons will never refer to me, despite all the work that I do, trying to get them to use us as a first line. But I think it's improving.
Can I ask then, if a woman does ask for physiotherapy, what's the waiting list like?
At my hospital is about 2 months at the moment, but it varies. So at King's College Hospital, there's no GP direct access to pelvic physiotherapy, so they're already referred into the consultants before they can get to physiotherapy. And really, we should be first line from a GP rather than going into secondary or tertiary care.
And how big is the private sector in terms of physiotherapy?
It's quite significant, yes, and there's a lot of interest in pelvic health physiotherapy in the private sector, partly driven because women can't access as much in the NHS as they would like, and the nature of the work makes it very suitable for part-time physios working unusual hours. It fits in around family life, which a lot of the patients want as well. So it's quite a thriving area at the moment, but expensive.
It is. Thank you very much. Valerie, did you?
Yes, I'm just curious about that gatekeeper role, really, to access specialist pelvic physiotherapy. I mean, I'm not sure of the numbers, but as you say, you turn up at a consultant, you may have a waiting list of months and months before you get to see them. That's months by which you haven't had access to the specialist physio that might have been necessary before the consultant even really looked at you. So the option for the GP to make those referrals, presumably that isn't happening. They're not being able to access specialist pelvic physios.
Not routinely, no. And some GPs are not aware of what services are being offered in their area. in my area we set up GP direct access, which is great, but we still have GPs referring straight into the Urogynae team, and we're trying to establish a much clearer pathway for that, because it's not necessary, it's a waste of time and money. But I'm also really keen that we look at new and inventive ways of getting the physiotherapy information out to patients. So out of around 44,000 physios in the UK, there's only around 800 of us who are pelvic health physios. And clearly, without a huge investment of time and money, that's not going to change anytime soon. So we need to be much more creative about how we go about this, which is partly why I created Squeezy, because that makes sure that you've got good evidence-based information that patients can access. That my professional body has leaflets, information on its website that patients can download as well. And yet, despite the amount of information on the internet, people still don't know where to go or where to get their quality information from. So I think there's still work that can be done in making sure women are aware of the pelvic health problems that can happen, how common they are, that we can treat them, not to suffer in silence. All of those aspects also need to be dealt with, so that we are clearing up some of the minor problems before they become bigger problems.
Can I just ask, the obstacles to setting up GP direct access, is that as a result of, or because there's so few of you? What are the obstacles?
I think, yes, partly it's that, partly it's educating GPs and getting the information out to them, them understanding that pelvic health physiotherapy is a thing, that it's different from general physiotherapy. And often in the NHS, that we're so busy ticking off the boxes and meeting our targets, that actually taking that time out to plan a service and plan a change becomes very difficult.
Could I just ask about the distinction, or whether there is a normal distinction between preventive pelvic floor physiotherapy on the one hand and management of a condition, whether it's SUI or prolapse or whatever? I mean, well, I suppose firstly, in terms of what you see, what is the balance between the two? And secondly, when should the preventive message be getting through to people? At what time in a woman's life should they be introduced to the concept of good pelvic floor health?
I think it should start at the teenage years. We learn about our eyes and go to the opticians, our teeth and go to the dentist, but we don't even think about the pelvic floor most of the time. So I think when girls are reaching adolescence, the same time we're doing sex education and periods in schools, we should be talking about pelvic health. And for boys as well, I think everybody should be aware of this. And then when they're going through the postnatal period, we want good quality information. There is a drive towards every new mum should be seeing a pelvic physiotherapist, and I think that's a really excellent principle. But again, in practice, I can't see how we could achieve that at the moment. So again, we need some more creative ways around it. But the biggest area is the stigma, and we need to be talking about this more. My group Pelvic Raw on social media is all about getting people to know about pelvic health problems so that they're coming forwards at an earlier stage. And if women are doing their exercises and doing them correctly before they have children, we know from the evidence that we can reduce the risk of stress incontinence, for example. If you pick up a problem quickly and then go and get treatment, we know again from the evidence that we can have a significant impact. So it's starting at the sort of grassroots of basic information and making sure it's accessible, and that women are encouraged to talk about their problems and get help as soon as possible.
But I mean, one of the questions is, if you're saying adherence is quite low because people have to exercise every day rigorously, is there a way, I mean, how do you improve adherence?
I think there's a number of ways. We're looking at, we would like to set up a trial with Squeezy app, for example, because we know from the surveys that we've done and the subjective data that it improves people's adherence. We know that smartphones are the way forward for so many things, and Squeezy is designed that you can set reminders and it keeps an exercise record and so on. We know from the literature there are other ways of making contact with people, for example, and one study showed that if you rang a patient every day, their adherence went up hugely. Now that's not practical for most of us, but there are developments that we've made, for example, with Squeezy that will allow your app to be connected to a clinician platform. So there's ways that we can use the technology to further that. we're also looking at ways of having online consultations or questions and answers with a professional. And what I've seen in the MESH group is that women will often ask questions that other women are answering because they don't know where to go and get a professional answer. And sometimes it's something really simple, but it's getting an answer from a source or a person that you trust that's really important when there's so much out there. So I think if women understand the importance of what they're doing, then I think that will help adherence. And if they understand that these conditions, particularly incontinence, are treatable, which a lot of women still think they just have to put up with it, or it's a normal part of having children or a normal part of aging. And so getting rid of those myths, I think, will take us a long way forwards to getting the adherence.
And are there sort of products as well as apps that will help?
Yes, there's a huge variety of products. So for stress incontinence, you can use incontinence pessaries such as Contiform, which will help support the urethra. Use those in the vagina so patients can put them in themselves if they're doing sports or exercise, for example. When it comes to prolapse, the range of pessaries is phenomenal, and yet we hardly use them in the UK. And there's still a massive amount of misunderstanding around them. But 70 to 80% of women can be successfully managed with a prolapse with a pessary, which again they can sort out themselves. The most expensive pessaries cost £50 and last for up to 10 years. So it just seems complete madness that we're not exploring this option more.
Why do you think that we don't use that option?
Again, there's a lot of myths around them. So traditionally they were used if you're waiting for surgery, and I still hear patients say, well, my doctor says I'm too old for a pessary, I'm too young for a pessary, so I'm not sure what the golden age is for a pessary. And doctors traditionally haven't used them so much because they're a conservative tool, but physiotherapists aren't trained to use them, and I fit pessaries, but it's considered to be an extended scope role for physios. So if it's a conservative role for the surgeons, an extended role for the physios and the nurses, who is supposed to be fitting the pessaries? So we need to be addressing that, and that's something else that I'm looking at with my professional body, is how we can introduce that more for physiotherapists. Patients don't like pessaries often, and I see so many patients who say, but I want it fixed. So they're not understanding that if you operate on a prolapse, there's still a 20 to 30% chance of recurrence, but we're still seeing surgery as being the answer in many cases, obviously less so now. And again, it goes down to education. We know that pessaries are a degree of guesswork, and it takes on average 2 to 3 attempts to get the right pessary. But often it's try a ring, falls out, you're not suitable for pessaries. So it's something else that needs a little bit of time taken to set it up and get some clear training, guidelines, understanding in it.
But if you're saying that's not a surgical option, so surgeons don't sort of do it, physiotherapist is an extended option, who does it?
I think it should be physiotherapists and nurses.
Right.
I think we should start with it being gynae specialists, getting guidelines clearly established. We don't have any good guidelines in the UK, but they have excellent ones in Australia, which I'm basing my work on. And then we need to be training and spreading out to GPs and practice nurses.
I think we've got to draw this to a close, sadly, because I'm sure we could go on longer. But I just have to say, Myra, if you've got things you'd like to ask us, we're always available, open, accessible. And certainly there may be questions we want to come back and ask you, and I hope that would be possible.
That's fine, yeah.
But thank you for all the work that you're doing,
Thank you.
helping women in this way. Thank you.
Thanks very much.
Thank you.